Okay. Speaker view. Good afternoon, everyone, and welcome to this afternoon's webinar. So before we start, I'd like to introduce our guest speaker. So she's a 50-year PhD student in biomechanics and neuroscience and graduating in January 2021. So she's a Winnipegger, and she's actually in Winnipeg right now, and at the University of Winnipeg for her Bachelor's of Science in Biopsychology with honors before heading west to Kelowna for her master's. Her research has always focused on the effects of a concussion on the brain's ability to function, and she became interested in studying persistent concussion symptoms and post-concussion syndrome after hearing so many stories from friends and family about people who weren't getting better from a concussion. So Kelsey's PhD project examines symptoms, quality of life, brain function, and balance in adults with persistent concussion symptoms. So this afternoon, I'd like to introduce you to Kelsey Bryck. So Kelsey, thank you for having us. Thank you for this opportunity for you to present to us today. So I'd like to ask everyone to please turn off your camera and turn off your microphones, and you will have opportunity to ask questions at the end of the presentation. So I'd like to give this to the floor to Kelsey. Thank you, Kelsey.
Thank you very much for having me. All right, let me share my screen here. All right. So thank you for the introduction. Yes, I'm born and raised in Winnipeg and back in Winnipeg now. Currently just finishing up my PhD at the University of Delaware in the States. So I came back to Winnipeg about 3 weeks ago, and I've just been here working on my dissertation since then and continue to do so. Like Gladys mentioned, I will be finishing probably in January. So my research is always, or at least my PhD research is always focused on post-concussion syndrome in adults. So I basically, my background, like what was mentioned, is I've looked at sports concussion history of concussion and sport-related concussion. And then I started doing my PhD and realized that there was this whole group of people between the ages of 25 and 65 who not only had a brain injury, but were just not getting better. And so that is what my dissertation has now focused on. What I'm presenting today is not what my specific research is. If anyone wants to talk about that in the future, my email is at the bottom of this slide here. I love talking about this and love talking about my research, so please feel free to reach out to me. What I'm talking about today is kind of an overview of concussion and post-concussion syndrome, and just sort of where the research stands today. As a full sort of disclaimer before I start, I'm a researcher, I'm not a clinician, I am not any sort of physician, therapist, anything like that. So what I'm presenting today is very research heavy. So if you have any questions about that, or you want sort of a list of papers at the end, I am more than willing to share my slides, share my references, anything like that. So we'll get started here. So this is just an outline of what I'm going to go over today. We're going to sort of talk about where we stand with concussions, some misconceptions about them, and we'll dive into post-concussion syndrome. A lot of research lately has now focused on these clinical concussion trajectories, so I'll sort of briefly introduce those and talk about, you know, how they help to manage concussions and post-concussion syndrome, and we'll sort of, there'll be a little bit of sprinkle of exercises medicine in there as well. So just to kind of back up before I even dive into concussion, we classify traumatic brain injury as mild, moderate, or severe. And this is just a table showing sort of how we go about doing that. Everything I'm going to be talking about is based on the mild traumatic brain injury, or MTBI as I'll refer it to. And so a couple things to note here, just some misconceptions right off the hop is Loss of consciousness, you'll see it says none. You can have no loss of consciousness and still have a mild traumatic brain injury. So this is a huge misconception that still lingers out there today. I've met people who are still, today shocked to hear that. Same idea with post-traumatic amnesia or memory loss. You don't necessarily need to have any memory loss in order to have a concussion. And in terms of actually imaging of the brain, most of the time you are not going to see anything on a brain imaging scan. In fact, actually in the research world and for my dissertation, we exclude anybody who has a traumatic brain injury where they did have a positive imaging or their imaging showed something on their brain. So getting into concussion, there's mild, moderate, severe. I just mentioned that. Anywhere from 70 to 90% of TBIs are considered or classified mild, and we do not grade concussions anymore. So this is another sort of misconception that still lingers out there. And a lot of research, even when I'm going through it, sometimes I'll notice that, some of the older stuff from 10, 15, 20 years ago say grade 1 or 2 or 3 concussion. So those grading systems no longer apply. There's many reasons for that I'm not going to dive into today, but I just wanted to sort of bring that up. Again, as I mentioned, you don't need a loss of consciousness to have a concussion. Same thing with amnesia or memory loss. We cannot diagnose we cannot diagnose a concussion based on imaging. Imaging is typically used to kind of rule out other things, kind of a process of elimination. Another thing too with concussion is that symptoms may not appear right away. So part of my role in Delaware has been to test our student athletes at baseline when they first show up at Delaware. And then if they have a concussion, we follow up over several different time periods. I have had several student athletes who said, oh, I got hit in the head Wednesday night during my practice or during my game. I went home, did my homework, made dinner, went to sleep. I was totally fine. Woke up the next day, had a bad headache. They were dizzy, light sensitivity, things like that. So it's not unheard of to sort of have these symptoms come on gradually instead of immediately following the head impact. And something else that I'll dive into a little bit later is this idea of not sitting in a dark room until your symptoms resolve, but just giving yourself some cognitive and physical rest for 24 to 48 hours following the injury, and then doing other things after that. So I'll dive into that in a little bit. In terms of, how are people getting injured? This is a graph that I pulled from the CDC website earlier, and I've used over and over again in presentations. This shows the mechanism of injury between 2006 and 2014. Now, this is US data. I suspect that it does not differ very much from Canadian data. I just couldn't find the Canada data. But we see here, this one blue line at the top stands out from all the rest, kind of clustered at the bottom here. This mechanism of injury is unintentional falls. So falls are the main mechanism of injury across almost every age group, but especially when we sort of lump everybody together, this is the number one mechanism. And then the second most common mechanism is being unintentionally struck by or against an object. So a lot of the sport related concussions are going to be lumped under this category. And then the third most common is motor vehicle crashes. So I'm going to show this table. There's a lot of numbers here, so I'll sort of break it down. We can ignore most of it. I have little boxes to sort of highlight different numbers. So at the top, the pink part there is just, again, the mechanism of injury. You can see motor vehicle crashes, unintentional falls, being struck by or against an object. On the far left here it breaks it up into age groups now. So this is kind of taking the graph we just saw and breaking it up by age. Still at the bottom here where it says total, we see that, unintentional falls is the highest number, again, most common mechanism, followed by being struck by or against an object, and then motor vehicle crashes. This trend sort of stays consistent among most age groups. There's a couple of exceptions though. For anyone age 15 to 24, the most common mechanism is being unintentionally struck by or against an object. So again, this is the age range that a lot of concussion research is focused on. So your high school and your college student athletes. And again, this mechanism encompasses a lot of the sport-related concussion. And then the age group up from that, 25 to 34-year-olds, the number one cause is motor vehicle crashes. But what's consistent is, it's usually these three that are the top three mechanisms of injury. The other ones that they considered looking at were just a mechanism unspecified, intentional self-harm, and assault. And then just kind of a separate group of, they didn't really have any sort of mechanism specified. So in terms of assessing concussion, I have included sort of what's recommended by this consensus statement that exists specifically for sport concussion. And then on the next slide, I've included a couple other assessments that we do at Delaware and others that, research is sort of going down this path of we need to do more than just what's on this slide. But right now, what is said in the consensus statement is, looking at symptoms. That's always been kind of the number one thing. Usually a cranial nerve function assessment as well. Neurocognitive assessment. So cognition is just how your brain functions. One of the most common neurocognitive assessments is the impact, and we use that one at Delaware. For the most part, these assessments are going to test like your memory, your reaction time, just your ability to sort of process things. And then the other thing is balance. So a lot of the time, there's one assessment out there called the SCAT-5, which assesses sort of static balance. And it's got one small portion where you're walking, but it's not a big aspect of the SCAT-5. The standing or the balance assessment, again, for the most part has always been standing, sort of with your eyes closed, different positions, see if you make any errors, like you fall out of place and whatnot. However, more recent research is really focused on sort of more so your ability to walk, and especially walking and talking. So getting your brain working while you're walking, because you think of our everyday lives, we're not just walking thinking about nothing. Usually we're on the phone, whether it's talking to a friend, texting, looking around, thinking about what we're going to do for the day. Your brain is sort of always going while you're walking. So we've tried to mimic that in sort of a lab setting. And I'll get into that in a bit. That last part that I was talking about, the walking and talking, is actually where my dissertation research is heavily focused on. So if you want me to dive more into that, feel free to reach out for me. I'm glad to do so. Some other assessments that should definitely, I think, and the research world thinks should be included is testing vestibular and ocular assessment. So there's something called the VOMS, or vestibular ocular motor screening. I have a YouTube link here. I'm not going to play it for the sake of time. But what it is, it's a series of different assessments that basically it looks at your eye movements. So, the first part will be sort of follow my finger back and forth, up and down. I'm not sure if you can see me or my slides, but up and down, follow my finger. You'll put two fingers out in front of the patient and then get them to look, sort of keep their head still, look from left to right, back and forth, look at the eye movements. Are they smooth? Are the eyeballs shaking? Same thing, fingers go, up and down. The person looks up and down. Then we look at near point convergence. So we have a popsicle stick with a T on it. We bring that T in towards their nose, tell the person to stay focused on it. If at any point that T splits into two and they get double vision, we ask them to tell us when that occurs, and then we stop the stick and we take a measurement between their nose and that stick. We do it a couple times, get the average distance. Those are kind of the more the ocular assessments. And then for vestibular, what we're doing is you stick out your thumb in front of you, stay focused on your thumb, shake your head back and forth a couple times to a metronome, flip your thumb sideways, then you're looking up and down like you're saying yes. The last one is a bigger movement. This one is usually the one that brings out the most symptoms. So just as an example, I've had some football players, maybe unsurprisingly, who come in for an assessment and they say, no, I'm fine, I'm good. We get through all the tests and, you know, they're okay sort of thing. But we do this last test and it makes them feel horrible. And that tells me that something else is going on. So what it is you stick out your thumb in front of you, stay focused on it, and you're doing like a full kind of 180, staying focused on your thumb, left to right, back and forth. That one can definitely be the most provoking. Tandem gait test is something that we do in our lab as well. So this sort of touches on that walking and talking aspect. I'll show a video in the next slide. It's actually from our lab. And then just, you know, looking at history of headaches or migraines, history of a concussion, any psychological issues and alcohol or substance abuse. Those are also things that definitely need to be considered by, I think, any healthcare provider that's looking after a patient with concussion or PCS. So here's an example of the tandem gait task. This is actually my friend Katie, who I think is listening in, performing the tandem gait test. So you're walking heel to toe, get that away, heel to toe from one end of a 3-meter line on the floor and back. What we do in our lab is we time them. So what she just did, we time it. We stop in between each time, record how long it took them, and then we do it 4 times total where they're just walking. And we look at how, you know, the average time and the best time of those 4 trials. Then we do it 4 more times, but we get them to answer some questions while they're doing it. And so those questions are spelling 5-letter words backwards, subtraction by 6s or 7s. We kind of, as the administrator, decide on that. And then listing the months in reverse order. So if I said March, you would start walking, but you'd also say February, January, December, November, and go back. And then we sort of look at not only how you know, fast they're able to walk when they're talking as well, and compare it to when they're just walking, but we also look at the cognitive accuracy of when they're talking. So of the number of answers they gave us, how many were correct? So that's the tandem gait task. There we go. So in terms of symptoms, we hear a lot about symptoms, and as I mentioned, assessing them is, of course, very important. In the research world, at least, we split symptoms up into sort of these 4 different categories. And there's a lot on this table here, so I'm going to block off a whole bunch of it, and we'll go through each column individually. But the different categories are physical, cognitive, behavioral and emotional, and sleep. So for the physical ones, these are the ones that we sort of think of most commonly: headache, dizziness, nausea, ringing in your ears, any light or noise sensitivity. And headache and dizziness are the 2 of the most commonly reported symptoms post-concussion. Then we have the second category, so cognitive, which is essentially brain function. This is, you know, difficulty concentrating, remembering, just feeling slowed down, like you can't think, issues with problem solving or planning in the future, things like that. Emotional and behavioral is the third category. So this is more of the psychological issues such as anxiety, depression. Maybe you're more emotional, more irritable, you're more easily frustrated, things like that. And then the fourth category is sleep. So anything like trouble falling asleep, staying asleep, sleeping more or less than usual. These are all things that should and are typically assessed following a concussion. And one thing that I kind of want to make clear too is one patient is not going to fall into one of these categories. It's probably most likely that someone will fall into every category at different severities. So we'll kind of transition into post-concussion syndrome specifically. To talk about post-concussion syndrome and persistent symptoms, we need to know what the normal recovery time is for a concussion. So in adults, that's approximately 10 to 14 days. And in children, it's a little longer. It's about 4 weeks, so a month. When we say persistent, that is anything lasting beyond this normal time frame, any one or combination of the symptoms I just mentioned. persistent symptoms are thought to occur in anywhere from 15 to 40% of patients with MTBI. So some of you might be thinking, okay, that's a huge range, 15 to 40. There's a couple big reasons for that, and I'll sort of walk us through those. So the first one, the biggest one, is that there's really no standard definition of post-concussion syndrome, unfortunately. I sort of mentioned that there was a consensus statement on sport concussion. Nothing really like that exists for post-concussion syndrome, especially in adults. Just to sort of illustrate this, there was a 2015 study that they surveyed a whole bunch of physicians across all sorts of specialties and said, okay, if you have a concussion patient, how long do their symptoms need to last before you would consider a diagnosis of post-concussion syndrome? And so essentially the bottom line is that the answers were all over the place. There was no sort of one time frame or duration of time that the symptoms needed to last for these physicians to diagnose PCS. And that's what's illustrated in this graph here. So in the bottom, we have the different options of duration that the physicians were given to choose as their response. And on the sort of up and down axis there, that's the percentage of physicians that chose that answer. So we see the tallest bar here in this bar graph represents the most physicians basically said someone needs to have symptoms for at least 1 month up to 3 months. Or sorry, not up to 3 months, anywhere between 1 and 3 months. But you can see there was at least, a handful of physicians that chose one of these answers, of all of the answers that were given to them. So again, there's no real consensus in among these physicians. And then additionally, what I thought was very interesting and surprising is that right at the end here, almost 10% of these physicians said they don't even use a diagnosis of PCS. So that's sort of the other big issue in this world is there's a big controversy about the existence of post-concussion syndrome and or the cause of it. So those things lead to, that big range of saying 15 to 40% experience prolonged symptoms, and has really sort of added to the frustrations in at least the research world for me in terms of assessing and really figuring out what's going on. Most of the time, we can all agree that it's, any persistent or prolonged recovery from a concussion. And again, something I've sort of mentioned already is that these persistent symptoms can be any one of the symptoms that I mentioned already or others. I didn't include every single possible symptom. So this physical, cognitive, emotional, and or sleep. Now, one other area of this PCS research that I find very interesting is looking at being able to predict who may have prolonged symptoms. And so this next slide here just covers a couple of risk factors. And so I've separated into pre-injury and post-injury. And for anyone who's more familiar with the research world, there's a couple references on the far right there. But in terms of pre-injury risk factors, simply being female is one of them, puts you at greater risk for prolonged recovery. History of concussion and prior psychiatric history can also predict a prolonged recovery from concussion and or family history of. So those are our 3 pre-injury. And for post-injury, if you acutely or immediately following the concussion have a greater number and or severity of symptoms at that time, that is also a risk factor for prolonged recovery, including acute headache or migraine. The other thing, I sort of went over the vestibular and ocular motor assessments. So if you have dysfunction on that VOMS that I mentioned, that is a risk factor for prolonged recovery as well. And in fact, the two references there used the VOMS to come to that conclusion, and then sleep disturbance as well. So I mentioned those sleep issues that may arise after a concussion. If you're having those, they can be a risk factor for prolonged recovery. That being said, if you have any one or combination of these factors, pre or post injury, that does not guarantee you're going to have prolonged recovery. These are simply just risk factors that we can take into account. So basically, take-home message of that is that predicting PCS is hard at this point. We don't have concrete evidence for any one or combination of risk factors right now. They're just something we can take into consideration. Some of you may notice that I did not mention any sort of risk factor or loss of consciousness or post-traumatic memory loss being risk factors. There is a lot of research out there that says they are risk factors for prolonged injury. There's also a lot of research that says they are not. So the ones that I presented on the previous slide have more research that says they are a risk factor versus not being risk factors. Loss of consciousness and memory loss at time of injury, and a lot of other potential predictors. Very mixed evidence right now. So just wanted everyone to be aware of that. So how can we manage post-concussion syndrome if we don't even have a good definition of it? There's no standardized method of assessing it. Great question. So we need to consider something called clinical trajectories. This is from a group in Pittsburgh, and I know a lot of people in the research world of PCS have now gone down this path and really used these clinical trajectories to sort of either classify PCS and or help guide the management of it. So I'll run through these. And again, this is out of Pittsburgh. So these are the 6 different clinical trajectories here on the figure I have. I'll go through each of them very quickly for those who aren't familiar with maybe some of these terms. So vestibular is essentially talking about your balance. It is a very complex system that, I'm sorry for the healthcare providers listening, the vestibular system is very complex, but to summarize, it is your balance. And there's ocular motor, so just your eye movements. We have the cognitive trajectory. So again, this is sort of the being able to think, remember, focus, that kind of thing. We have the migraine trajectory, the anxiety and mood, and the cervical, which just means your neck. Now this next slide is I'll kind of walk us through this one. So one thing to be aware of is that these trajectories can co-occur and they can occur independently. So what this graph is showing here is just a sort of sample patient. So I'll just kind of orient you on this graph here. So any arrow that's reaching the outer blue ring here is someone who would be normal in that trajectory, meaning that they're not complaining of any symptoms related to those trajectories. And the shortest arrow here, kind of at the top, there we go. The shortest arrow is indicating that this example patient is primarily complaining of vestibular issues. So likely some dizziness, vertigo, nausea, that kind of thing. However, it's not just vestibular for this person. We see that the second longest arrow here is, or second shortest arrow, sorry, is pointing to the purple ring, which means that they have secondary complaints of a migraine. So maybe they had pre-injury migraines and now they've gotten worse or more frequent, or they never had them before and now they do. Either way, something's going on. This person is experiencing migraines that need to be considered. And then their tertiary complaint falls under a category of psychological health. So maybe they're indicating that they have increased anxiety or depression since their injury. So the takeaway from this is that one person is not going to fall into just one category. They might be a combination of 2, 3, 4, all 6 of them. This is just a good way of sort of classifying concussion and post-concussion syndrome patients. So this slide here, the pie chart is showing just sort of the frequency of people who are reporting which profile or which trajectory as their primary complaint. So we see there's one number, comma, and then a percentage. So we'll just look at the percentage for our sake, but we see that migraine is the most common at 26%, followed by anxiety and mood. Again, these are the primary trajectories of concussion patients. And this study specifically was done in sport-related concussion. I don't think a figure exists like this right now for non-sport related concussion. And then the table down here is just showing the relationship between all the trajectories, and if you know you're primarily falling into one category, what are you most likely to have as a secondary profile? So there's a lot of numbers here. We can just kind of ignore them and focus on the first two columns here. But you'll see, you know, if you're, for example, we'll take the second line here. If your primary profile is ocular motor, you're more likely to have a secondary profile of cognitive or fatigue. So basically not being able to focus kind of thing. So these are some, I guess, associations that I think we also need to be aware of. So how can we use this information in order to actually manage PCS, especially? So we'll go back to this lovely graph here. I'm going to walk through each one of these and sort of what the research recommends as the best options in terms of management and therapies. Again, disclaimer, I'm not a clinician. These are not my recommendations. This is kind of just what the research is saying. So we'll start again at vestibular. So again, the best thing is vestibular therapy, especially with a physical therapist who's trained in vestibular therapy. So I have, alongside my dissertation work, I've been shadowing physicians who deal with PCS patients. And the most common route, I guess, that I've seen in terms of people who have primarily vestibular complaints is going to a physical therapist and getting vestibular therapy. And like I mentioned before, the vestibular system is extremely complex. And so someone who's really well trained in vestibular, in the vestibular system can do a very comprehensive exam and figure out specifically what in that system is going wrong. And that can help guide the therapy. And so for ocular motor, it's kind of the same concept, you know, going to someone who really specializes in this area, getting a comprehensive evaluation by this person. That person can also more than likely help guide what therapies you need. And then the third one, again, cognitive. This one's very interesting to me. So, you know, again, this is the one where you're primarily complaining of issues with memory, focusing, concentration, things like that. My bullet points here are, you know, based on several different research articles over the last 10 years. One of the most common ways that I've noticed is, you know, regulating sleep especially, but just sort of finding a routine in life. Whether that's with your diet, hydration, going for a walk, exercise, keeping up with that kind of stuff. And then the other thing I've noticed just from, you know, shadowing for the last number of years, different physicians who manage PCS is, you know, just sleep aids. Regulating your sleep is very important in terms of your cognitive function or your brain function. The other thing I've heard a lot of is brain games. If you can find, you know, online brain games, if you can handle that screen time, online brain games are fun and they're helpful. I have heard of numerous people who have benefited from online brain games and just, you know, a couple minutes a day, see what you can handle. The goal here is to not exacerbate any of your symptoms. But yeah, online brain games seem to be a popular route to go. And then occupational therapy. So I know there's some occupational therapists listening in as well. And I know, again, I'm not a clinician, so any OTs, you can sort of correct me on this if I'm wrong, but I know with an OT, you can specialize in brain injury. And I've heard a lot of very good things about people who didn't even know what occupational therapy was or that this was an option for them. and their lives changed when they saw an OT following a brain injury. So something to keep in mind for sure. And then for migraine, the best route I've heard of for this is pharmacological intervention, so medication. I don't know what's available here in Canada, but when I was shadowing the physician in Delaware, he would prescribe these injectables for migraines, which are relatively new on the market. I forget what they're called, CRPGs, I think. And I would say 80 to 90% of the people that we saw in the clinic reported their lives were vastly improved once they got on this. And he, again, this is something that even if someone's primary complaint is vestibular in nature, getting the migraines under control was a huge part of that if that was another complaint of theirs. So tons of people have benefited from this. That being said, this is obviously something you would need to discuss with a physician. I am not prescribing this or suggesting that that's your route to go. I'm just saying that this is something that is a very good option, very promising option. And then exercise. So for mainly cervical issues or neck issues, physical therapy seems to be the best way to go. Again, medication, something like anti-inflammatories for pain. And then anxiety or mood, the last one. So big thing for this is getting the right therapy. And, of course, medications can help, but I think this is one of the less thought about persistent issues. And it's very, very important in my mind. Again, it may not be the primary complaint of someone, but it definitely feeds into if someone's primarily reporting other things, like a migraine, for example. If your life has changed by severe migraines, the chances of you having increased, anxiety or depression is huge. And so I think this is one of the trajectories that absolutely needs to be considered all the time. And there's a huge space for mental health professionals to be a part of PCS management. And exercise, again, I've mentioned that a couple of times, and I'll sort of dive into that briefly here. But exercise is a big one too. I feel like most of us know the association between exercising and improving your mood. So it's definitely something that can help as well. All right. So yeah, exercise is medicine. Those of us in the research world have heard this over and over again. I'm sure those of us in the clinical world as well have heard this over and over again. So in terms of post-concussion syndrome, there's a lot of research now coming out in the last 5 years that really supports using exercise as basically a management option. And so PCS is thought to be sort of a physiological dysfunction of the brain. And by that, I mean there's changes in your brain blood flow that should or should not be occurring, and that your body's nervous system is just really, it's not functioning the way it should. And so one example of this, I think I mentioned the consensus statement on sport concussion earlier. So this is a good guideline document about how to assess for sport, how to assess for sport concussion, sort of the steps to take afterwards. And as part of that, they included a return to play strategy, or return to sport strategy, which focuses on sort of getting someone moving again. So if you can see at the bottom of this table here, it says, note, an initial period of 24 to 48 hours of both relative physical rest and cognitive rest is recommended before beginning the return to sport progression. And then after, once you sort of get over that, the first step of this return to sport strategy is to just kind of start introducing daily activities that don't provoke your symptoms. And then after that, we start, for our Delaware athletes, we'd get them cycling on a stationary bike with their athletic trainer, team physician. And just a slow pace, nothing, crazy. We're not throwing them right back into sport or anything. But this is a good example of sort of a step-by-step way of reintroducing exercise and getting your heart rate up. Now, that being said, nothing like this, again, exists for post-concussion syndrome or non-sport related mechanisms that I'm aware of. If anyone is, please let me know. But so basically, I sort of mentioned this at the beginning, a little, misconception that I even hear today talking to some physicians is you get a concussion and you just completely rest, physical and cognitive rest until your symptoms resolve. There's the classic sit in a dark room, don't do anything for however long it takes. I think if you put any healthy person in a room for X amount of days and tell them to do absolutely nothing, anyone is going to, not feel good during that time. This is something that has been, there's strong evidence to say, don't do this. This is not the way to go and may actually lead to a prolonged recovery. So now, I mentioned exercise. So we have the concussion. Concussion occurs. You have physical and cognitive rest for the first 24 to 48 hours is what people should be doing. And then you sort of start with this graded subsymptom threshold aerobic exercise. A lot of words there. I'll sort of break it down. This is something that you also want to go through if you've had a concussion. You want to do this under the guidance of a healthcare professional, like a physical therapist or your physician, or, I know the Concussion Clinic here in Winnipeg does this as well. So graded just means you're progressing over time. So you start with just increasing your heart rate on a walk, then maybe you can, increase it a little more next time, do a higher beat per minute type of thing. The subsymptom part is that you were doing these things and you are not exacerbating your symptoms while you do them. If you do, you stop. And aerobic just means you're increasing your heart rate essentially. So tons of evidence over the last 5 years that show this works. Unfortunately, in my case, or for me, a lot of this research focuses on either sport-related concussion, which is typically a younger group, so that 15 to sort of 25-year-olds. And you can see, this is just a table of all the research that's been done. You can probably see most of it has occurred in the last 5 years. And then under this mean age column, you can probably see that a lot of the average age of the group tested, or the age range, is very young. There's some that creep up into the early 20s. There's one here kind of in the middle that is 18 to 33-year-olds. But this is this is our high school and college athlete sport concussion group, which leaves a huge area wide open. And the only study that really tests anyone outside of this age range is the one that I've highlighted here, that focuses adults anywhere from 18 to 65, which is the population that I'm focusing on as well. So I thought this was very interesting. And this was a review study that came out earlier this year, just so everyone knows. So for the sake of time, I won't go through every single one of these points here. The numbers in brackets here are just correspond to the sort of reference, the little superscript numbers here on the far left-hand side. But the bottom one here, in adults with post-concussion syndrome, which these patients had symptoms for over 6 months by the time they started this study. They were in an interdisciplinary rehab protocol, so lots of people involved in their rehab. Part of this group of people did exercise as well, and part of them didn't. And those who did exercise had improved symptoms, social functioning, reduced mental fatigue, and increased life satisfaction. So just overall, how they felt about their life and their quality of life improved by just having this exercise. So we go back to this slide again. How can we manage PCS? Hopefully at this point it is relatively obvious that there's no one size fits all sort of approach to this. PCS management needs to be individualized, interdisciplinary. this is my own sort of opinion, I guess, but including mental health professionals is a huge part of it, I think. And exercise. Again, exercise, I think, as well needs to be sort of monitored by healthcare providers. I don't think it's safe to just sort of go out on your own. There needs to be some guidance with that, but it definitely needs to be included in the PCS management process. And the last thing I have here, it's just a bunch of links that I found. The one that I absolutely personally love is the bottom one here, the happy broadcast. Today's world can be very overwhelming and depressing. I love this link because it just gives you, there's a little example here, but little short blurbs of happy news around the world. I think it just starts off your day very nicely. So I recommend checking it out if you haven't heard of it. And then, of course, a lot of research went into this presentation. So this is the first half of my references in the second half. Again, if anyone would like that list or this whole presentation, feel free to contact me. My email is right there. You can find me on Twitter. I'm relatively active there as well, or LinkedIn. That's all I've got.
Thank you so much, Kelsey. So we're going to unmute you all. So yeah, if you have any questions, this is the time. And also for those on Facebook, you can type in your questions and then we can ask Kelsey about, and then she can answer your questions through the chat option for Zoom. So anybody in here on Zoom who has any questions?
So I have a question. Hello.
Hello.
Oh yes, Lana.
Well, I guess I was listening. Thanks for all the helpful information. And I was involved in a lot of, like I had a concussion in 2013 where I hit my head on the glass, hit my head on the glass and my head went to the right side, but I didn't realize I lost consciousness till later. And I claimed MPI and I told them that, and they said, you have to lose consciousness and all that and blah, blah, blah. So I went to see several doctors. I went to see, like right now, like I went to see a neurologist and they said, you're going to have constant ongoing, it's migraines. Cause when I go outside right now, it's 2020, right? I see sparkles in my eyes. And he said, those are migraines. And I also had in 2015, I hit my head on the